that I have no disclosures, no conflict of interest in this presentation. And to bring to the forefront, we know that our pediatric population is almost like 40%, and the commonest problems that these patients present, or the pediatric population, is the GI disease, of which constipation and diarrhea constitutes nearly 40%. And what is more worrying here may be diarrhea, which demands attention, and that the parents take time to the hospital. But what is most often ignored is constipation. And the prevalence rate is as much as 5-8%. Interesting. I just went up to the Google and tried to find out and realized that there's something like 2.26 lakhs entries being made as to what is constipation in children. So that it tells you the search that has been made, or people looked into it for support and help. So this article, Kanan et al. Of 2010, it's a very simple work, and they have analyzed cases of 137 and found that 85% of these patients, the constipation, and the remaining 15% was purely surgical, and of which 8 was first. The rest of the surgical, for example, congenital anomalies, etc., they were obvious at the time of birth. But what was not possible to be diagnosed in the first initial years of birth has been the Hirschsprung's disease. And then it brings us to the forefront that literature has been there, as in India. How do we look at our population and what have we done for it? And definitely in that there is a need for knowledge, there's awareness that is needed most. The surgeon, the child is not meant to go and sample. So it was interesting to read the Japanese story. This is of 2005 of Taguchi. He is a stalwart on Hirschsprung's. And they have 30 years of their cases of 3,850 patients. That's a number in a small country like this. And if you look at the pre-op and post-op mortality rates have tremendously dropped from year 1998 to. And how could their country? It is because the advancement of diagnostics. So the initial, whatever the diagnostic modalities came into existence for these surgical causes, especially Hirschsprung's, they all started in Japan. And they know that the organic causes like these Hirschsprung can only be cured by surgery and nothing else. So they saw to it that their surgical advancements went hand in hand and they were tailor-made. And then, and that all their cases were registered and followed up. And that the biggest effort in the industry. And with all this, of course, the neonatal care went hand in hand. But what about India? Advances in diagnostics was something that I dreamt 20 years ago, and I think I'm rather satisfied. The intensive neonatal care, yes, we have probably the good ones and good ones, not at all places. Surgical advancement, I think, has sort of been supported because of the diagnostics, but I'm not sure whether they're truly tailor-made for our population and the situation and scenario that we are in. And definitely not, we don't have a national registry. To have a registry, we need to have a good histocard diagnosis, and that is all with us as pathologists. So if we diagnose at the right time and at the right moment, and I'm sure, and archive all our cases and have them registered, we will have a national registry for Hirschsprung's, and it would do wonders for our children. So as WHO says, for constipation, it says needs timely value. If not, after all, what if that doesn't move its power? They say that the delayed intervention gives rise to something called a stool withdrawal, a withholding behavior, and has a great impact of psychosocial side. And because of withholding behavior, there's going to be stagnation of stool, the feces matter with the microenvironment being disordered, and there's an overgrowth of bacteria resulting in necrotizing enterocolitis. So that gives rise to an increased mortality rate. So in other words, what are we looking at? To decrease the mortality rate and help improve the child have no delayed milestones. So the need of the hour for these children with constipation is, as pathologists, differentiate the cause of medical versus surgical. So we need the trial to where we can say this child needs only medical line of treatment. No, this child needs surgical. And the second, and that means to see we take care of their diet. We know that this is influenced by diet or this is influenced by whatever habitual toilet training. All that comes into effect. And in turn, guide the surgeon as to when to use his knife. So the pathology primarily is medical versus surgical cause. And I want you to go, come along with me as we go through this journey. So this journey began in 1998. And this is a small graph. And that was in 11th of October. Can I have volume, please?
Everybody is valid. She still has not passed motion. So the surgeon takes a colonic biopsy and sends it to the Department of Pathology for rapid diagnosis. A frozen section is done. The consultant looks under the microscope and reports to the surgeon as Hirschsprung's disease. The surgery continues. But the consultant is restless. What's the diagnosis? The consultant looks at the slide again, and there it is. One ganglion in the corner, proving that it was Hirschsprung's. But too late. The baby had already lost its rectum. This was how we began.
And that was in 1998. And what that present is, and this talk I dedicate to all those children and the newborn who have made this work possible. So this Hirschsprung's is a very simple anatomical defect. It just means there are no ganglion cells and it is congenital. And many people ask me, if it's why can't we detect in life, in vitro, is that possible? But we should remember that the fetal body makes its first move only after it is born. So we will not be able to detect until the child is born. And that is why most of the suspected Hirschsprungs come in the first week or 3 days, where one looks at the passage of the feces that's being passed. This disease, Hirschsprung's, is a type of neurocristopathy. Neural crests have been emphasized right from the first talk by Dr. Ranganath. He said there are neural crests, ectomy. There are a whole lot of neural crests, and this neural crest gives rise to the ganglion cells, all the nuclei, out the intestine, all from the esophagus down to the stomach to reach up to the rectum. Such a long journey, and mind you, this all gets done in the first month of pregnancy, before the mother knows that she's with the all is over in the first month of conception. And this is rare in this country, like 1 in 1,000 live births. Whereas in India, we realize that it is quite get and it is as probably as 2,000 live births. And what is Hirschsprung's after all is just the missing part. It is just that what is found is not being thrown out. And that is because of the neural plexus that we have, the myenteric and the submucosal plexus are not able to make the muscle relax. And that is because there are no ganglion cells. So the basic pathology is that there are no ganglion cells, so the goes into parasympathetics come into role. So the parasympathetic overactivity makes the musculature go into spasm, they go into hypertrophy, and where the contents when passed on where they are supposed to relax, they don't know how. So the whole starts now. So once it goes, this is how normally should it be, but it does not happen in Hirschsprung. So it stops short where the ganglions stop moving. So here to say the ganglion cells are migrated, come along the entire length of the intestine and come up here. And we say this is the part of the rectosigmoid which has not been innervated. It is aganglionic and hence this is Hirschsprung. So neural crest is a time machine. So I was telling you this happens in the first month of life. So the thing happens in the 4 weeks. By the time the ganglion cells come to the ileocecal junction, a stimulus goes to the sacral nuclei. So ganglia move from there to migrate and to innervate this part. So these ganglions cannot come down unless they reach this place, give a signal to sacral implant, send their fibers up. So a lot depends on migration, proliferation, and differentiation of these neural crests in this innervation of the enteric nervous system, which is nothing but the brain. So this is the neural component in the intestine. It is the second brain. So the whole pathology lies here. We have a distended colon and a spastic rectum. Dr. Hirschsprung, when he first defined this disease, his findings were on 2 babies who died after at probably about 2 months life. And he thought that the problem was here. He never thought that the pathology was in this part of the distal rectum. And it was later, after much analysis, they realized that what is missing is the ganglion cell. So we are all used to looking at a disease caused by, but we don't really look at a disease by the absence of. So this disease is something very different, difficult, and the whole evaluation is like a mathematical formula. Is it present? Is it absent? So there is no, there's no subjectivity involved. So we pathologists have no problem if only we get the concept right in evaluating this spastic rectum. So what has gone in Hirschsprung, as I told you, first is no bowel to no response to rectal stress. So that is why the inhibitory reflex rectoanal is absent. There is no peristalsis happening. So the contents from the proximal colon is not to the distal part and out. And this loss is spasm and hence the narrowed lumen, and this is all because of the enzyme acetylcholinesterase. Patient or the baby when he presents, we have the bowel loops which you can so obvious, but if not for this, the baby is rather comfortable. But we do not know because it may go into sepsis at any moment of life. And when resected, we know that it is not it is here in this contracted bubble. So the more presentation of these is meconium bubble movement which throws out the feces, which is always bicolored. And these patients most often present as a chronic, that is why they present with constipation, delayed passage of meconium, and they need enemas. And because of all this, in other words, intake also is affected, they fail to thrive, and all this results in abdominal extension. But in the newborn, the presentation is rather acute. They present with intestinal perforation, most often in the iliopsoas junction. So the surgeon is not aware. He would take care of the patient, and the child will go back in of this. What will happen because the Hirschsprung's at the distal part is not recognized. So all these babies with intestinal perforation need to be followed 8 months and have a rectal biopsy to rule out Hirschsprung's. The severity of the disease depends where the neural crest is arrested. So to begin with, we have the ultrasound to involve the internal anal sphincter. So that is easy to handle because you just do a myotomy, open up, dilate, and the child is dilate. Let's just imagine a ganglion only in the distal. The gravity is sigmoid, which is up to 70 to 80%. And this is most common, and these static means say that one child has and the other child will also get. So it is not familiar in this situation. Next comes the long segment, which goes beyond the spectrum. This is to diagnose as well as patients need laparoscopy. Where a short segment could be treated with a per annum resection of the segment. And when the whole colon is involved, we have the total colonic aganglionosis, which can also extend to the distal ileum. And when the whole intestine includes small intestine, becomes a total intestinal aganglionosis, which is incompatible with life. Just people have malnutrition, parental nutrition, but in India it's a big hassle. We are not still into it, and I don't know how much of an effort for. Now coming to the diagnosis, which is the task of our today's, is the cardinal clinical features with which the patient is biopsied. The patient may undergo an anorectal manometry to assess the reflex. We have chest decrease, abdomen with contrast, that is barium enema. But not all these can be practiced when the baby has come with an acute. The biopsies, of course, is the gold standard. And let's look if genetic studies have any role to play in this case. Anorectal manometry in the words, how much can you expect with you? I want to cry, say cry, not possible, it will be crying all the time. So this is not practical in the newborn and maybe older children, yes, to some extent. Radiography, yes, tells you that there is multiple fluid indicating and lot of gasha indicating there is subacute intestinal obstruction. But what is to be noted is that there is absent gas in this pelvis. And these are the pictures which show that there is a microcolon, which makes think one of long segment Hirschsprung's or total colonic aganglionosis. This is of the rectal sigmoid. It's an excellent screening test, but not diagnostic. So the surgeon feels I must take a biopsy and send it across, rather than treat the child based on radiology alone. So the diagnosis of Hirschsprung's. Now let's move to the biopsy, which is conventional. on which we need to confirm with enzyme histochemistry. And of course, in those situations, we cannot subject the biopsy for enzyme, we confirm with immunohistochemistry. And of course, nothing like a good path correlation. And of course, whatever I say is the dialogue. You can have a sweet talk or you can fight over. Now, the goals of the pathologist at this moment with histopathological examination are threefold. The first one is the pre-op. Before the child is operated, yes, the surgeon needs to have a confirmed diagnosis so that he can go ahead and do the surgery that is required for that particular cases that is tailor-made. Number two is the intro. The surgeon needs exactly the support of the pathologist to say how much of the colon to be resected. So you need to remember that the child is growing and that if you cannot remove as much of the colon as possible, mind you that it will come in the way of absorb water, etc. So that is very, very important. Number three is the post-op, is to confirm your diagnosis that the pull-through surgery has been done. This is the and if we have such a biopsy, we will not have an issue because we can find the plexuses, that is the submucosal plexus and the myelinic plexus between the two layers of the muscularis. And then this is how you cut the echelon and they need an nerve a normal of the colon is the muscle mucosa. And this is how we identify the ganglion cells with the right at the center to identify and the ganglion cells. But what if the cut is above it or below it? You will not identify the nucleus. The nucleus is seen now. And moreover, the cut is much higher above. You can totally miss the ganglion cell. Don't see the ganglion cell. The biopsy become a ganglion. That means to say that this is once. So that's why I say if we miss identifying that ganglion cell and or if one so giving a surgeon directions to the surgeon to go with resection, and that would be the one stage, that means to start surgery in one go, or it could be two stages, that is we do a colostomy, relieve the obstruction, and call the child again back after some 4 months when the child is bigger and bring the two ends together. Or it could be where he takes a biopsy, then a colostomy, and then the reunion. So just imagine this baby which is just born has to undergo through these three major abdominal surgeries. And also, when do we do the colostomy? It's so difficult for the to take a colostomy, change, and none of our people. So the local and manage the child and the manage and child with its movements, it's going to be very difficult with the colostomy. And they also land up with residual problems. They might land up with constipation again or incontinence if the dissection is little lower down to affect the sphincter. Or they could still land up with some kind of enterocolitis. So we know that diagnosis of Hirschsprung's or enteric innervation status evaluation mandates a surgical therapy when we don't see ganglion cells. And only 30% of these cases of Hirschsprung's with constipation. And the non-Hirschsprung cases need medical line treatment. So we differentiate these that the non-Hirschsprung cases do not undergo any kind of surgery at any moment of time. So the diagnostic criteria on a rectal biopsy of ganglion cells, and as a result, one see hypertrophic and hypoplastic nerve bundles in the submucosa. And this is the wall which is hypertrophic nerve bundles and the you see. So if this is the biopsy, it is very we would have no issues. But normally done is not take a full thickness biopsy. The surgeon like it for the further surgery that the child has to undertake. So what is mucosal biopsy? So in these biopsies, if one is a ganglion cell, it is not Hirschman. So you will hunt for that one single ganglion cell. So when you find him like this, measures to supposed to ganglion cell area, it is, and it is a frozen of tissue 2 millimeters. You would can probably take maybe about 40-50 centimeters very. And they can hemorrhage because while taking the biopsy, would be lymphoid having a follicle. Biopsy does the surgeon prefer? I have told you that there is no scar and it's suited. So best for him. It's economical. It can be done in the outpatient department. The child needs no admission. The parents are. And now when we get at, if we can prove it is absence of ganglion cells, a negative finding, how do we do that? It is giving yourself into a bit of fragment and trying to search. It is what it is. Hey. It's just so we extrapolate the fact that to do that we have to probably not less than 60 to 70 serial sections. You examine each one log that it has ganglion cell and not ganglion cell. So the story stop here. What if the section taken away has a ganglion cell? So always bother and we have plus 9. But things are different by this method of standard traditional method of staining for black polymeristic. A lot of changes. The only thing it takes 3 hours of any procedure. Isopentane, nitrogen. We do not have lab. We need trained staff. Modify this and modify it, and we in our own simple cryostat that we have for general purpose, using the principle that these biopsies ganglion cells have increased codes. So you can demonstrate that the activity is increased and the positive finding is something to make a specific of Hirschman's, and it's called the gold standard for Hirschman's disease by the American Association of Paediatrics. Now, with biopsy, so on the rectum, we have the dentate line which differs distal anus from the proximal rectum, and we have a zone which is known as the physiological zone. It's no ganglion cells, or rather maybe 1 or 2, but it's definitely hyperganglionic. We have the serosal nerves here by which they innervate the distal part of the anus. So in the bargain, they also innervate this. Suppose if a biopsy is taken at this moment, point, you have no ganglion cells, you will see a lot of nerves. So here is great mimic. Yes, you're going to call. And so people not to have a piece from this, but you know, he will know, but still, it is difficult at all times to have a right height. So I'll show you how we came over this problem, and we now have biopsy about the inner and we never ask for a repeat biopsy on a child. And we tend to give or we manage or we somehow, all means that we make a definite diagnosis and recommend whether surgery should be done or not. The sample is received in eyes because it needs 30 not beyond, where it damages the enzyme, nor can it go through the routine paraffin because the day is 60 degrees. So the only back tissue has fresh, and the tissue that comes in has to be wrapped up in a saline soaked gauze to keep it wet, and that goes into a polythene bag, and that goes into a box which contains ice cubes, so that during the transit we set as much as 25, the tissue is still good enough to reach our lab. And as this is the tissue that, and it is frozen, sections are cut, and we have this procedure of modified rapid method, which used to take almost like 2.5 hours. But with modification, we have brought it 30 minutes. So as a turnaround time that one would ask for a frozen, which is 20 minutes. Here we take another 10 minutes more, plus 5 minutes for mounting, clearing the hydration. So the mucosal biopsy as it is here, this is how a positive case of Hirsch looks like. So you see these cholinesterase activity seen as dark fibers which are green. These are just come up between the to the surface. And this is as a 3 branch of Hirschsprung. So me is diagnostic. And it's not when you this is how it stings. So whether positive or negative on that. This stain here, which is a situation where there are ganglion cells but may not have got picked up, it stains occasional ACHE positive fibers, telling you that there is, yes, this tissue is stained and works well. So this is the normal ACHE activity when it is ganglionated. So this is the classic pattern E, and this is likened to the street branching pattern. We have the pattern being stains the lower half of the like compared to the stream. And we have a problem with the newborn, which stains only the submucosa. It doesn't see the mucosa. It is only here. So this is the equivocal pattern with hypoplastic nerves including the neonates. And this is what is most often missed by many people who are accustomed to ACHE, and they may call this as negative and make a negative diagnosis. So the time got shortened from whatever 2.5 hours to 30 to 40 minutes. And I like to say that there is no false positives or false negatives in this particular staining rule. And there is no interval of observer discrepancy. So the kappa agreement is 100%. So it doesn't matter, is it positive, is it yes or no? And there is no believe. I know you cannot say, oh, it may be, it may not be. And it has been proved so far in 2,200 biopsy study. I presented this work at the US CAP meet in 2014, and it is going on. So what we have been looking at, whatever 60 sections here, is now reduced to just 2 section lines. So the cutting gets done in 5 minutes, 1 minute to freeze that small tissue, 2 minutes to cut, and the cheese slides are ready. After that, it takes 30 minutes. And we presented this, I got published for the first one with the law in 2003. And we had the MR project which we could take forward, and we shown that this problem, which was the most difficult to diagnose in newborn. In this period, we had all our children coming if they were one, but every other case is and many are. These children born ganglion cells like any of these endocrine cells of the liver. Very difficult to say ganglion cells not. Whereas it's very easy in an adult. See, so much is the difference. It's very different from adult. Now, this tissue is so small, which is less than 2. How do we do this? How we do on the chart? And if we know one, we color them so that we don't spend in each one separately. They are brought together. And this is how it is negative. We just have one bundle here saying it has work particularly. This is in a case of a neonate 3-day-old. If we have it to here, you see this pattern. And this is Hirsch trans. And what I was trying to focus that this says never biopsy at this level, but we have ventured into and we make commitments. See that we have fibers. This is so even we do not refuse, we go ahead and stain, and it works perfectly. So we need to change this line in the textbook saying that whatever will be the biopsy, if it is about the anal, it should be fine for assessing enteric nervous system. And this is the low level ACHE is like biopsy. And what a biopsy, I'm sure it is called as inadequate. What? This is only a mucosa, actually with little. Where is the mucosa? There's a mucosa. But it shows a pattern and it is positive. Yes, it is Hirsch. But if it has no staining pattern, then it demands a repeat biopsy. And then we took this frozen. We were wondering how do we get tissues from far and wide? They have to send it fresh. It's not possible. So we tried to do this with a transport medium, which was, we called it as the St. John's medium. We tried our own method. And with that, we had tissue coming from Meghalaya. After 5 days, we cut a frozen because the tissue was autolyzed. And this is how we didn't know which was mucosa. But here, same with the AC and the increase in the zone mucosa of Hirsch trans. So that made us use this transport medium to ship them and ask them to. And that was something that we felt very good about, and that we use with confidence using ACHE on biopsy sent at the end of 5 days when the actually completely. But the problem with ACHE is, yes, it's highly labile, needs fresh tissue, sent in an ice pack, and when we need to within 20 hours or in the end we can keep for 5 days. That is true. But further away, what if the surgeon has put the biopsy formalin? The way we have a gold standard. So that brought us to do a study on calretin. The calretin is a calcium channel marker, and when the muscle is in spasm, a lot of calcium is used, and hence the nerves and the fibers that are there show calcium ions readily available for ganglion. It's both plasmic stain. But what we look for is not for the ganglion cells with calretinin, but we look for intrinsic to the mucosa. If these are stained, it means to say ganglion cells. So this is a normal innovative biopsy showing calorie positivity, eating that. And this is muscularity trips, exact cholinestis, biopsies, and mucosa. So in a normal mucosa, you have ACHE, which is negative, but calretinine is positive. And what you see as dots control cells. And we have the hypertrophic nerve bundle, which is seen here as well, which is not stained. And with histile cholinestis, you have a pattern. These two things put together definitely confirm that the biopsy is Hirschman's. So we wondered the right choice. We wondered, can we extrapolate to staininess? But if the case of Hirschman comes in formally and we do a keratin, it is a negative stain. So can we run a biopsy if the stain is negative? We prove with confidence, yes, it is a ganglion. So it's not. So we do many other neural markers to kick on. In the meantime, we had this which compared keratin IHC with the improvised method. Could I one more test? Please go through it. So now the started for a post-marker rectal mucosa because the keratin negative, not negative marker. We tried and some markers I have put here show that none of them are really good. The keratin remains the best, but there's no solution thereafter. But then we realized that neural is a very nice marker which stains something plastic, but doesn't and stains the hypertrophic nerve bundles here as well. And we said, let's look at post transfer, but the good one. In the nerve bundles, the keratin, the group one is the basis. Yes, in much better. If we have keratin, forget the work as a positive marker. But if it worked in some, it didn't work in. It depends on the nerve. So we have perfect and calcium. The biopsy, it would be clear. This is not one case is not like the other. And then we said there has been many questions with juniors. This is a ganglion. What do you call it? This could be a Schwann nucleus. So we tried this marker with SOX stain only the but does not stain the ganglion cell. So if you are in doubt, please do a SOX stain. So the quest for positive marker is still going on. It's not been solved. And I'm sure one day you have a marker which precisely and it can be done so. Next is the goal of the histological examination to an intro. Here comes the things which have to be taken levels that this ganglionic so they can bring down this sector upward to the. So the biopsies of the leveling are C-shaped. This is something this shape because of the contraction of the muscle released from the colon as frozen, and this is how we pick up the ganglion cells in the mind plexus. Pieces of tissue are very, very minute. And if one stains it, this is how they stain brightly and early. But the whole problem is that the tissues are small. And the cell as many as 6 biopsies, and you cannot be cutting at a time. Get and color that are available, and they cut through the frozen, and this is how the sections come out at the end of it, and finally go through the paraffin, and this is how the paraffin sections come out with those colored inks. So we know that green is at one and they are documented. We have this for any to practice is called as the improvised double analysis. This method can be employed for anything other than to have histology tissues. Next came the donut to say that resected and this is to be brought down and anastomosed. We have to prove that the innervation of this is perfect, and this is called as the donut. This donut is analyzed 4-quadrant wise so that we assess circumferential innervation of this entire donut, and this is called ABCD for short. And this is done so because the neural migration, the neural cells migrate only in all quadrants, so leading than the other. So as it happens, at this point you can answer, and if a surgeon takes a biopsy at this point, you will say it's ganglionic. Rest of it is agonic, and this is not going to work when after the surgery. So he sends the whole dose. So we look at it circumferentially, and it is done cryostats and stain with. So once is one of the nerve, and at this moment we please go proximal and take out much more of the tissue by about and tries and take for frozen ABSs. So that's where the paper is on the design of normal recovered tissue. So as you confirm and that easier, so you access and say how much of it of the colon ganglionic. Genetic practical value and does not affect clinical management, but only it would answer many questions when there are conditions of the red gene. Think of red and mutations, and especially seen in long segment and TCA cases. So you mental mutations that you should look. Yeah. So is there a way to measure nutrient deficiencies during pregnancy? But then the child, the nutrient much before the mother said she was already pregnant. It is said that it would be beneficial if the deficient plan she would take with vitamins, and of course not use maintain healthy. Of course, this aspect of vitamin B has been borrowed from the preconception folic acid as pathologists do to make the right diagnosis at the right time and help to have the surgeries at the right time. So what is a registry, and that's possible if only if we do outing and the basis perfectly. Of course, a multidisciplinary approach of the child, and of course, pathology saves 1,000 pounds. And this is how the number has been studied, that only 28% of biopsies report Hirschsprung. To say 72 were just biopsy for a suspicion and they were proved normal. If they all undergone some kind of surgery, we say by so we continue to support the thousands of children and on each one of you to get into this venture and make these children's mind in this. Thanks a lot for listening to my saving 1,000 colons.
Thank you.